you, and good morning, everybody. With great pleasure, we introduce Dr. Janaron. Jana, my apology if I mispronounced your name. Janarardhan. He has been assistant professor in medicine, section of hepatology at Rush Medical Center, Chicago, Illinois, since 2015. He earned his medical degree and PhD in immunology and residency in internal medicine and fellowship in gastroenterology and advanced research as a part of medical science training program and physician scientist development program at University of Chicago. He's currently board certified in internal medicine, gastroenterology, and obesity. His clinical focus is a care of patients with chronic liver disease, specialized in metabolic syndrome, associated steatosis. His approach to care emphasizes lifestyle modification and other intervention to optimize metabolic comorbidity. He's a director of the weight intervention and liver clinic pathway, and he leads the comprehensive weight loss program housed within Rush University Hepatology Clinic. He's also founding member of the Rush Metabolic Health Multidisciplinary Collaboration to promote awareness, education, research, and comprehensive patient care plan for metabolic syndrome-related disorder. His research interests include optimization of care pathway designed to treat obesity, metabolic syndrome, in patients with chronic liver disease, as well using computer technology to facilitate chronic liver disease management. He served as a principal investigator and participated in many medical advisory board in several clinical trials in NASH, hepatorenal syndrome, BBC, and refractory ascites, and co-investigator in several of other clinical trials related to chronic liver disease. He also served as an industry consultant for his expertise in metabolic syndrome. He's also taken pride in mentoring the education and research effort of student and house staff. That's what I was told. And we have Dr. Bartnick. She's a board-certified transplant hepatologist and gastroenterologist specialized in transplant hepatology. Dr. Bartnick earned her master's degree in public health from University of Michigan, her medical degree from Michigan State, and she completed her internal medicine training at Emory and fellowship at University of Pittsburgh. She is the director of liver clinic at Corwell Westside, and I would like to introduce her as well. Thank you.
Okay, so a lesson is never write a bio unless you want the person to read the entire thing. All right, so here we are. It says 21 minutes. I want those additional 4 minutes put back because I'm going to need all of them. So every time I give a state-of-the-art lecture, I keep telling people that we are so close to the next therapeutic for NASH. And I can just hear my daughter in my head going, are we though, Dad? Are we really? Or are we still a little bit far away? Or if we look at it from a different perspective, are we already there? These are my disclosures. So during the course of the talk today, we wanted state of the art. We are going to get the brand new, literally released yesterday at 9 a.m., nomenclature and disease definitions and diagnostic criteria for what we used to call fatty liver disease. We'll discuss the disease states known as NAFLD and NASH and the associations with metabolic syndrome and the clinical burden that they currently and will represent. We'll talk about novel screening pathways for identifying patients that are at high risk and talk about available therapies for NASH as well as the experimental therapies that are in development. We'll talk about the benefit of weight loss, that's my area of specialty, and how we can implement weight loss strategies in subspecialty clinics. So NASH no longer exists, so sorry, this talk is completely poorly named. There is a new name, definition, and diagnostic criteria. I wanted to highlight the importance of the difference between NAFLD and NASH and implications that has, the global prevalence, again, metabolic syndrome, and the burden of disease. So, as of yesterday around 9 a.m., they released an article presented at the EASL conference, the European conference, that we're not going to call it fatty liver disease anymore because as an obesity medicine provider, having a metabolic syndrome disease that has the word fatty in it is slightly offensive. not slightly, but pretty offensive. So it's now called steatotic liver disease. So just going through this here, this is broken down into multiple components. So the traditional NAFLD that we used to talk about is now called metabolic dysfunction associated steatotic liver disease. Now it is a mouthful. I actually suggested this when I was a first year attending, and somebody told me that it's too wordy. So recognizing the fact that people have metabolic syndrome and drink alcohol, there's a new entity known as MET-ALD, and that's what people are calling it. So it's if you drink more than a moderate amount of alcohol, but also have metabolic syndrome. And they break that down into people that are more MASLD predominant or metabolic predominant, or more alcohol predominant based on the amount of alcohol that a person uses. If you have no metabolic risk factors and you drink a lot of alcohol and have steatotic liver disease, that falls into the alcoholic liver disease pathway. You also could have just a specific etiology, such as drug-induced liver injury, monogenic diseases such as Wilson's disease, hypobeta-lipoproteinemia, inborn errors of metabolism. And then there's miscellaneous disorders like celiac disease, certain types of hepatitis C. And then finally, if you have no etiology for your steatotic liver disease, that falls into this cryptogenic category, and that can be very challenging, especially if it's associated with significant damage. So the initial evaluation of anyone with steatotic liver disease is first thinking about, hey, what are the metabolic risks that this person has? Because as you can see here, the risk of having components of the metabolic syndrome when you have NAFLD or NASH is very, very high. So you're looking for things like visceral adiposity, their body shape, acanthosis nigricans, you're looking at neck circumference. But the other thing that's really important is that 35% of the population has this, right? So that means that 35% of the people with any other chronic liver disease will also have fat in their liver. So it's important to rule out the other etiologies, and that's usually done with laboratory tests. Oops, sorry about that. Usually done with laboratory tests here. Also, obviously, attributed to this is ruling out the other etiologies. So these are some of the secondary causes that can cause steatosis in the liver, so LAL deficiency, hypobeta-lipoproteinemia, Wilson's disease, and then some of the miscellaneous etiologies like we talked about, celiac disease. Also have to rule out, obviously, drug-induced steatosis. So amiodarone, the common things, tamoxifen, methotrexate, and corticosteroids. These are all available on the AASLD guidelines, and so if you want to look up the clinical scenarios in which you'd suspect these things, that's where you should look. So breaking down into how you determine which group you're in. So once a patient has been diagnosed with steatotic liver disease, you want to ask yourself, do they meet cardiometabolic criteria? And basically the cardiometabolic criteria are the components of the metabolic syndrome. Do they have one of at least of elevated BMI or elevated waist circumference? And remember, it has to be ethnically adjusted. Do they have elevated blood sugars or insulin resistance? Do they have elevated blood pressure, triglycerides, or HDL? And there's a different criteria for pediatrics. If they do have those criteria, then you have to ask, is there a secondary cause of steatosis? And if not, then you're in your MASLD group. If you have a secondary etiology, then if it's alcohol, then you're in that MET-ALD group or another combination etiology. If there are no metabolic risk factors, you have to say, are there causes of steatosis? If there are, then that is the etiology of your steatotic liver disease, and if not, then you're in the cryptogenic group. So we want to highlight the difference between MAFLD and MASH, is what they're now called, or MASLD and MASH. So this group probably knows the difference between the two, but in MAFLD, you have just simple steatosis, just fat in the liver. There's a minimal amount of inflammation or fibrosis or cell death. And the reason this is important to distinguish from NASH, where you do have inflammation and cell death in the form of this ballooning hepatocyte that's actually undergoing apoptosis, and the microtubules are kind of breaking up and the cell's just exploding or dying. As well as this characteristic chicken wire fibrosis, where the fibrosis kind of circles each of the hepatocytes. The reason that's important is because it has a significant impact on disease progression. So it's estimated that about 30% of the patients that have NAFLD, or I'm sorry, I'm going to refer to them as NAFLD and NASH because I'm still trying to learn it in my head. About 30% of the people with NAFLD will have NASH, and about 40% of those patients will progress. The average progression rate is actually really low if you take the entire population, because some people don't progress at all, some people progress rapidly, as you can see in this figure. And some people actually will regress. The thing that seems to affect progression the most is the metabolic syndrome comorbidities that are present. So the reason this is so important to distinguish NAFLD and NASH is that NAFLD has a good liver prognosis, NASH does not. So this is looking at the NASH CRN, which is a prospective collection of one of the earliest databases that we have of NASH. And if you see here in the group that has no fibrosis up to moderate fibrosis, the risk of liver-related decompensating events is very, very low. There is an increased risk of death from any cause because of the fact that these people have a metabolic syndrome disease, then their increased risk for cardiovascular disease. But once you get to stage 3 or stage 4 cirrhotic fibrosis, you can see that the liver-related decompensating events really increase dramatically. And the death from any cause increases dramatically, but in this context, the death is caused by liver disease. So when you have advanced liver disease, when you have advanced fibrosis, then primary cause of death is liver-related mortality, as opposed to early fibrosis, it's cardiovascular-related mortality. And on the left, what you're seeing here is that there's actually a dose-dependent response in terms of the level of fibrosis and your risk of these morbidity and mortality conditions. So what predicts whether a person will have NAFLD or NASH? And honestly, it's the metabolic syndrome. That's probably the best thing that you can use in clinical practice. So looking here from the NHANES study, if you have 3 components of the metabolic syndrome, about 40% of people will have NAFLD. But if you have all 5, that's up to 70%. So using non-invasive measures, they also looked at what's the likelihood of having advanced fibrosis, F3 or F4 disease. And you can see here, if you have 3 components, you only have about 7% risk of developing, having advanced fibrosis. But if you have 5, you have 30% risk, right? 30% risk. So 1 out of every 3 patients that we see in clinic with 5 components of the metabolic syndrome, which is not that uncommon, right? How many people have hypertension, waist circumference, triglycerides, HDL, and diabetes, right? That's not that uncommon. 1 out of every 3 of those patients will have advanced fibrosis and probably doesn't know it. So we talk about, okay, only 30% has NASH, and only 40% of those will progress, right? It sounds like a really small population, but the denominator is huge. So it's estimated that about 35% of the population in North America and South America has NAFLD, right? So that makes it 3 times more common than diabetes. So even if you just take a third of that group that has NASH, that means the same number of people that have diabetes have this advanced liver disease or aggressive liver disease. Really, the prevalence parallels obesity. Both are expected to have a prevalence of about 50% in 2040. And there's certain factors that do increase your risk of, or your prevalence of NAFLD, being male, having obesity, obviously, and diabetes. But this was a really interesting meta-analysis because they looked at the studies that were published before 2016 versus after 2016. And this study was published in 2022. And in just 7 years, 5, 6 years, the prevalence increased from 25% to about 32%. So just showing how rapidly this is increasing. But it's not just that the prevalence of NAFLD is increasing, it's that people are dying from it, right? So this is modeling studies that were presented yesterday, showing the rates of liver decompensation, liver-related mortality, and HCC in patients with NASH, and how it's modeled to increase. So in 2015, the incidence of liver-related decompensation was about 40,000, going up to over 100,000 by 2030. Same thing with liver-related deaths, 30,000 progressing to 80,000. We don't have the resources to take care of this patient population if that's the level of rise we have, which is why therapeutics are so important. And we certainly don't have enough organs to transplant these patients. So this is showing, we saw this yesterday, that the fatty liver disease is now the second most common cause of liver transplants, and it already is the #1 cause of liver transplants in women and those over age 65. And if we look at the fold increase from 2002, you see that NASH is rapidly outpacing all other etiologies, including alcohol, in terms of becoming the #1 indication. So how do we find these at-risk patients? So there's new screening guidelines that we can look into, and what are our options for treatment? So this is the general approach to screening patients and treating patients with NAFLD. We want to look at the group that has the highest risk. So what are those patients? The patients with prediabetes, medically complicated obesity, or those who are incidentally found to have steatosis or elevated liver enzymes. For this group, we want to rule out secondary causes, and then you have your MASLD population. So obviously for the people that don't have advanced fibrosis, the main thing that we want to focus on is preventing cardiovascular disease, because that's the #1 cause of death. But we also want to make sure that these people don't develop cirrhosis. So that goes into fibrosis risk stratification, which we'll talk about next. So this is from the ASLD guidelines. The population that they recommend screening is those with type 2 diabetes, those with medically complicated obesity. They also bring up the MET-ALD group, those with NAFLD who have a moderate amount of alcohol use, because the steatosis that's induced by alcohol is synergistic with the steatosis that's induced by metabolic syndrome, and they have a higher risk of advanced fibrosis. The other group that we should screen that not many people are aware of is anyone who has a first-degree relative with NASH cirrhosis. They have a 12-fold increased likelihood of developing NASH with advanced fibrosis, so they should be screened. So how do they get screened? So in primary care or non-GI hepatology care, the recommendation is just to use the FIB-4 test. So the FIB-4 is your AST and ALT, platelets, and age. So just using that test, we're able to determine one thing and one thing only, that they have a low likelihood of having advanced fibrosis. That's the only thing that FIB-4 is really good for, is saying you do not have advanced fibrosis. It doesn't rule out that you have moderate fibrosis or anything like that. But if they do have low likelihood of fibrosis, then they can be just monitored in primary care and discuss lifestyle modifications for treatment of metabolic syndrome. And if they have a low risk, they don't have diabetes, and they have less than 2 metabolic risk factors, you can rescreen them every 2 to 3 years, or if they have more risk, every 1 to 2 years. If they have a high FIB-4 and there's a high likelihood that they have more advanced disease, they should be referred to hepatology or GI. But there's a big group that's going to fall in this intermediate category. And so these patients that are in the intermediate category need a secondary risk assessment, and that's done with transient elastography, most commonly FibroScan or ultrasound elastography. Or there's a blood test called the Enhanced Liver Fibrosis Test that's available in all the commercial labs now, not always covered by insurance, that you can also use for risk stratification. So if they're low risk in that secondary group, they go back to primary care. If they're intermediate or high, they end up in GI hepatology, and that's where we get them. So our job is to make sure that the diagnosis is correct and the level of fibrosis is correct. So the first thing we might want to consider is additional risk stratification with something like MR elastography, or if the diagnosis is in question, then considering a liver biopsy, just to rule out secondary causes, or to be completely clear about the level of fibrosis. So if we find out that they're low stage, so stage 0 to 1, we can reassess them in 0 to 1 years and again talk about lifestyle modifications. If they're stage 2 to 3, this is a high risk group. We want to reassess their fibrosis annually using whatever modality worked, probably not biopsy every year, and then consider pharmacotherapy or other aggressive measures. If they're stage 4, obviously we then need to start monitoring them for complications of cirrhosis, as well as being very aggressive now with interventions to halt their NASH. Okay, so what are the currently available therapies? There's no FDA-approved treatment for NASH. The guidelines recommend using semaglutide in the patients who otherwise have an indication for it, obesity or diabetes. Pioglitazone and vitamin E were studied in the PIVENS trial and do have a marginal benefit, and those can be considered in the appropriate population. Like we talked about yesterday, statins are safe. They don't treat NASH, but they are safe to use in this population. And obviously you want to treat the metabolic syndrome with treatment of hypertriglyceridemia. URSO, DPP-4, statins, and milk thistle, which a lot of your patients will be on, have no role in treating fatty liver disease. Bariatric surgery is very effective, and we'll talk about that later. So let's talk about some of the experimental therapies that are thought to be closest. So in any clinical trial for NASH, the goal is to improve fibrosis by 1 stage without worsening histologic evidence of NASH, so the inflammation and ballooning, or to resolve NASH without worsening fibrosis. So this is obeticholic acid, and about 22% in their interim analysis, the second interim analysis, had improvement in fibrosis compared to only 9% with placebo. NASH resolution was not as impressive, but they also had a lot of side effects with itching. So about 55% of people did have itching. It was the most common side effect, but it didn't cause discontinuation of drug that frequently, but it was the most recent cause. The most common cause. The problem is that they did have other side effects. And so this was the FDA committee advisory review. I know you can't see this at all. I apologize about that, but I just want to walk you through it. So they took a look at the benefits versus the risk of obeticholic acid, and they looked at the absolute risk reduction of the absolute risk improvement of having an improvement in fibrosis. And the difference was about 8.6 compared to placebo versus the highest dose of OCA. And in terms of resolving steatosis, the benefit was only about 4%, 3.7%. But then they also looked at the difference in the incidence rate of complications. So there was a low but measurable increase in hepatotoxicity in some of these patients. The incidence rates for cholelithiasis was slightly increased, but again, it does cross 1. Dyslipidemia was significant. A lot of these patients did have to go on a statin or have their statin dose increased, but it's not a pathogenic dyslipidemia as far as we know. There was no increase in MACE events, and usually this does recover over the course of 12 months. The other problem, though, was that there was increased dysglycemia. Sorry about that. So more patients that had worsening control of their diabetes or progression from diabetes to prediabetes to diabetes, or from normal glycemic to prediabetes, and then we talked about the itching. So based on this, the advisory committee did not recommend, thought that the risks outweighed the benefits, and they did not recommend approval. And unfortunately, because of that, Intercept, the company that makes this drug, decided to discontinue their OCA NASH program, which was a major hit for all of us in the NASH world. It was also a major hit for the patients that are benefiting from this drug, and obviously those stakeholders whose livelihood depends on this. So some of the other agents for NASH. So this is semaglutide, which we already know is a diabetes and obesity agent. In their phase 2 trial, they showed about 60% of people had resolution of NASH versus only 17% with placebo. So that was impressive. They also had an impressive improvement in fibrosis. About 43 to 49% had improvement in fibrosis without worsening of NASH. The problem is that just like any clinical trial, you never know what's going to happen. Here, the placebo rate was about 33%, right? That 33% is better than any of the therapeutic agents that I'm going to talk about today, and that's the placebo rate. But that's just the nature of the beast, so we're going to wait for phase 3 data. We do know about the GI side effects of semaglutide, bloating, nausea, et cetera. Some of them were severe, but only about 7% discontinued treatment. You guys might not be able to see this, but in terms of metabolic markers, so the triglycerides did reduce by about 25%, AST and ALT by about 50%. People had about 12% body weight loss, and the A1C improved by about a point. So some positive metabolic markers. This is looking at a thyroid hormone receptor beta agonist, resmetirom, for NASH. And this was just recently released information looking at resmetirom at 80 and 100 milligrams. We saw that there was a significant increase in NASH resolution at the higher dose of resmetirom, as well as a significant improvement in fibrosis compared to placebo. The drug was actually pretty well tolerated, low rates of study discontinuation, maybe a little bit higher in the higher dose group, and is mostly diarrhea and nausea. But importantly, this drug was first made for improvements in lipids, right? So you see that there's a dose-dependent response in LDL with this agent. And in another, not arm of this trial, but a separate trial that they did, you can see that there's a dose-dependent decrease in LDL, ApoB, and triglycerides, as well as liver fat with this agent. So ultimately, as we think about this, it might be that combination therapy is critical, right? So maybe we need semaglutide or a GLP-1 agonist to help with weight loss and diabetes control. We need a thyroid hormone receptor beta to help with dyslipidemia, and we need an FXR to help with fibrosis. So that's probably the future, and studies like this are already ongoing. So what about bariatric surgery? So we think that there's a significant benefit to this. So this was a meta-analysis of 32 cohort studies that showed improvement in inflammation and ballooning in 50 and 76% of patients, and improvement in fibrosis in 40% of patients. Now, this was interesting. About 12% of people had new or worsening fibrosis. We don't know exactly why that happened, but it might be due to very rapid weight loss. There's one center in France, I don't know what they're doing, but they have the most amazing data, and they continue to report it over and over again. They have NASH resolution 84%, complete resolution of fibrosis in 56%, and decrease in 70%. So no one else has that data, but so I don't know exactly what they're doing, but they're doing a good job with it. So it's not just that bariatric surgery improves fibrosis, it's that it improves outcomes. So this is looking at adverse liver outcomes in patients who had bariatric surgery versus non-surgical controls, and this is a significant difference. And there's also a significant difference in MACE events, adverse cardiovascular outcomes with bariatric surgery versus non-surgical controls. And from a metabolic standpoint, obviously there's a significant benefit of weight loss with bariatric surgery and reduction in A1C. So is the best therapy already here, right? So we see that weight loss, lifestyle, all these other things seem to be very effective. So what are the effects of weight loss and lifestyle change in NASH? And can we implement those in our clinics? So this was a study in Puerto Rico where they used a low-fat, high-carb diet, not the ideal diet for fatty liver disease, in treating patients with NASH. And you can see that if you achieved 7% weight loss, there was a significant portion of the population, about 65%, that had NASH resolution on biopsy after 1 year. And if you achieved 10% weight loss, 80% of the patients had improvement in fibrosis. Now, this data has not been recreated in other studies, but we do see that these thresholds seem to be important in terms of changing histology from 7% and 10%, but the magnitude has not been that big. So what are the specifics in terms of lifestyle intervention? We want to avoid diets that are high in simple carbohydrates and saturated fats. We want, the Mediterranean diet is the one that's most popular. We talk about it all the time with NASH, but recently the Medina trial in 2022 showed that there was really no benefit of a Mediterranean diet over a low-fat diet. So really it's about what diet is sustainable. And usually from an obesity world, that's a diet that's high in protein and low in glycemic index. We talked about this yesterday. We want to have a modified approach with resistance training and high protein if you're cirrhotic. In terms of exercise, anything is better than nothing. But again, from the obesity world, we know that the 150 minutes of exercise is really just for maintenance of general health. It's not necessarily effective for weight loss, where you need closer to 200 to 300 minutes. And if you want weight maintenance, you need closer to 300 to 400 minutes. But again, anything is better than nothing. In terms of changing histology, you need one component to be more vigorous, either the duration of the exercise or the intensity of the exercise, and that was shown in a really interesting study. Alcohol reduction. So the CDC is going to come out with new guidelines that say no amount of alcohol is considered safe. And ultimately, that's probably true. So anyone with low levels of fibrosis should be advised to reduce their alcohol. And if you're F2 or above, you're playing with fire, and so complete abstinence is recommended. So this was our approach to weight loss in the weight intervention and liver disease pathway. In 2017, I got certified in obesity medicine. My APPs that were at Rush were really excited about it. They got certified through the OMA as well. And we started this program where patients were referred to our clinic if they had medically significant obesity in terms of a chronic liver disease. The criteria has changed over time, but they get initially scheduled for an intake visit. It's an hour-long visit where they do a full obesity assessment, just like you would have in any obesity clinic, where we're screening for binge eating disorder and other psychiatric diseases. We're talking about obesity pathophysiology so that people understand why we're recommending the things we do, because if people have controls to the machine, they're more likely to operate it. We talk about exercise prescriptions, not just recommending. You know, we don't just walk in and say, hell yeah, eat less, exercise more. That doesn't work, and it's not calories in, calories out, right? We need a little bit more specific details when advising our patients, and that's what training in obesity medicine can help with. And obviously, in a busy hepatology practice, you don't have time to do this, and this is where APP support can be really helpful. We do use pharmacology when appropriate, and as well as referral to surgical intervention when appropriate. So they meet with my APPs once a month until they hit their goal of a 10% body weight loss, and then follow up as needed. We'll come back to this if we have time, but I just wanted to show I'm looking at Dr. Kanukin, who told me you're never allowed to skip a slide. So our general approach to weight loss is that, again, it's evidence-based. We want to empower via education for obesity physiology. We follow a low-carb, high-protein Mediterranean diet that's also high in fiber in order to induce appetite suppression, right? So the carbohydrate insulin model basically argues that high carbohydrate diets increase hunger and increase caloric intake as a result. So we look at low-carb alternatives and meal replacements, which has actually been shown to be one of the most effective methods for weight loss. Talk about psychologic support, and again, obviously tailor the individual needs to ethnicity and socioeconomics. So that's a really important point, right? If your patient lives in a food desert, you want to think about how you would talk about weight loss and resources. And we talked about pharmacotherapy or surgery when available, and the unique populations. So this is our outcomes just with a few patients, about 72 patients. We looked at our average weight loss in the program versus one of our APPs that's not obesity certified. It was about a 7.5% weight loss, so again, enough to change NASH histology. That was on average. But in terms of achieving those threshold marks, about 22% of patients in our pathway were able to achieve just 10% weight loss. When we compare this to the clinical trial that I told you about 10% of patients achieved it in that trial, and we look at routine care through the Target NASH registry, which is a real-world registry of patients with NASH, only about 11% of patients were able to achieve that. So some significant results. Obviously, this is still ongoing, and we're excited about it, and people are really motivated about it, and including our patients. It's over a 95% patient satisfaction rate. So it's something to think about moving forward. I am just about at 25 minutes, so I'm very happy to say that I'm on my last slide, which is to say that it's not enough to just be a hepatologist treating NASH, right? And it's not enough to be a primary care doctor treating NASH. It requires multidisciplinary care. You need a cardiologist or someone that's a lipid specialist. You need an endocrinologist that can modify glycemic control and things like that, then use the more advanced techniques. You need someone in food psychology, right? If a person has binge eating disorder and I recommend a restrictive diet, that's a terrible idea. But you have to be aware of these things. So that's why at Rush we have a metabolic health consortium that we're building with representatives from all of the components of metabolic syndrome with the goal of creating multidisciplinary care pathways and education. So this is, I'll just put these up while we have some questions. I do want to thank the rest of the group at Rush, including especially the Weight Intervention and Liver Disease team and the rest of my colleagues. So I'm happy to take questions while we have these conclusions up. Are we out of time? We'll do questions afterwards. Okay, perfect.
Advancement is this one.
Yeah, no, this is advanced. That's the pointer. This is backwards.
All right, good morning, everyone. Thank you for having me. So we're going to be taking a little bit of a shift toward the management of portal hypertension, and these are updates that were highlighted at DDW this year. So these are the key management updates. I don't have any financial disclosures. So what we'll be talking about is how important portal hypertension management is in our general GI practice in our patients with cirrhosis. I'll give a very brief historical perspective, talk about both secondary and primary prophylaxis with non-selective beta blockade, as well as this novel paradigm shift in hepatology, which is actually initiating carvedilol to prevent hepatic decompensation, and how do we do so in a non-invasive way by applying Baveno criteria. So we have to kind of understand where portal hypertension comes from in our cirrhotic patients that have advanced fibrosis and very stiff livers. That ultimately will result in splanchnic dilation that will lead to decreased effective arterial circulation that activates the neurohormonal pathway with renin, angiotensin, aldosterone that leads to sodium and water retention and ultimately hypervolemic. So when we're examining our patients in the office, they're ultimately, most of them are very hyperdynamic from the increased cardiovascular output. And our traditional non-selective beta blockers, nadolol, propranolol, for instance, have antagonistic properties towards the beta-1 and beta-2 receptors, but where carvedilol is advantageous is the alpha property. So it does block the intrahepatic vascular resistance, and we'll go through some topics in detail. So taking a very big step back and thinking about what clinical applications we had available in the 1980s. So in our patients that presented with variceal hemorrhage, they were largely treated from a surgical approach. So our surgeons were able to do a distal splenorenal surgical shunt. Unfortunately, that was not a very good long-term option for these patients. The mortality was quite high. Banding wasn't available. We had limited access to somatostatin therapy. The outcomes were quite short, and the rebleeding risk, unfortunately, which drives that mortality risk, was quite high. In the 1980s, there was a landmark article by Lebrecq, published in the New England Journal, looking at the principles of propranolol by reducing cardiac output and reducing blood circulatory volume. They applied propranolol in the secondary state after variceal hemorrhage, and what they found is that propranolol significantly reduced mortality after presentation for variceal hemorrhage. There's a big issue, though, with propranolol in that 20 to 50% of patients actually don't respond. So what we mean by that is they do not have a reduction in their HVPG, the hepatic venous pressure gradient, which is measured invasively, and that is defined as a greater than 20% reduction. Unfortunately, increasing the heart rate, so increasing the dose of of propranolol, which lowers the patient's heart rate, doesn't correlate with reduction in portal pressures. And we know that the correlation, unfortunately, is quite weak. Oftentimes in clinical practice, we're trying to drive that heart rate down. So by 20% is what we consider sufficient, or to a goal of 55 beats per minute. But unfortunately, unless we measure invasively, we don't have reassurance that that patient is actually responding appropriately. Bañeres in 2002 was able to show us that carvedilol is actually not only more potent, but greater rate or proportion of patients that are initiated on carvedilol therapy respond. So there was a greater mean reduction in HVPG in these patients, and a higher proportion of patients respond to carvedilol, and that was without the reduction in renal perfusion. So carvedilol has a number of advantages. It's metabolized by the liver. It has a longer half-life. It's more bioavailable. And theoretically, it can be dosed in cirrhotic patients once daily to improve compliance. Personally, in clinical practice, I continue to use twice daily dosing, but theoretically, this can be done. So does every patient need to be initiated on non-selective beta blockade? And so this introduces this theory of the window hypothesis. If you have a patient that's an early child A, perhaps score 5, that doesn't have any evidence of varices on initial screen, those patients really have a low chance of bacterial translocation. They have preserved cardiovascular reserve, and they likely will not benefit from initiating on non-selective beta blockade. Once they start to develop clinically significant portal hypertension, that window opens. They have that possibility of starting to their gut translocation occurs from the splanchnic dilation that I discussed, and so they may ultimately benefit. But unfortunately, once the disease advances, they develop refractory ascites, their hemodynamics change, perhaps that cardiovascular reserve is reduced, then they no longer will benefit. And unfortunately, it's up to us to decide where the patient fits into this window hypothesis. So in 2019, there was a big paradigm shift in the hepatology world. We started to think about primary and secondary prophylactic principles. Can we start to apply that to patients to actually prevent hepatic decompensation before the cardiac index increases or before the mean arterial pressure decreases, but still maximize the benefit, weighing the risks of the medications themselves? And Dr. Serper actually published a cohort-based study in February of this year looking at the data from the VA population in patients that were pre-decompensation, so compensated patients with cirrhosis that were newly initiated on either carvedilol or selective beta blockers. And what their group found is that carvedilol was associated with a reduced hepatic decompensation and overall liver-related mortality in comparison to selective beta blockade. In subgroup analysis, they did not find this to be beneficial in patients that were very early child A, in patients that were hepatitis C viremic, in patients that were advanced age, and in NAFLD-related cirrhosis. So does that mean that we should be, completely abandoning our endoscopic variceal ligation? Certainly not. Ultimately, this is a risk-benefit discussion with the patients. There's certainly pros and cons with initiating non-selective beta blockade either as primary prophylaxis or in prevention of hepatic decompensation. We have to consider the cons of these medications. It's a daily medication that the patient has to take. There are side effect profiles related to this. For instance, sexual dysfunction, hypotension, bradycardia. In the flip side, esophageal band ligation as primary prophylaxis also comes with risk. We know these patients tend to bleed more due to secondary band ulcerations. In addition to that, the patient needs to come back for serial banding sessions, and they have to have a driver with them. So there's a financial implication not only for the patient, but also for the family member or caregiver. So how do we apply this in our general GI hepatology practice? It's certainly not feasible to calculate or obtain an invasive measure like HVPG on every single one of our patients. So do we have non-invasive markers for fibrosis that can help guide which patients we should be initiating on non-selective beta blockade? And in fact, we do, and that comes from the Bovino criteria. I'll speak a little bit about the history of the Bovino criteria, and I want you to think about the Bovino as, do we need to be performing screening upper endoscopy for the identification of portal hypertension in each and every single one of our patients with cirrhosis in clinical practice? So the Bovino consensus first met in 1990. Basically, the summary statement in 1990 was everybody, all comers with cirrhosis, when they come see you in the office, they should be getting a screening upper endoscopy to determine if they have high-risk esophageal or gastric varices. In 2015, Bovino 6 modified the criteria in that everybody should be screened with upper endoscopy except those with liver stiffness measured by elastography of less than 20 kilopascals or a platelet and a platelet count of greater than 150,000. Bovino 7 took it a step further and applied the principles that were initially introduced in 2019, where we're starting to initiate carvedilol non-selective beta blockade to prevent hepatic decompensation, and essentially said that anybody that doesn't tolerate non-selective beta blockers and has clinically advanced liver disease plus clinically significant portal hypertension, or patients with decompensation that were not already on non-selective beta blockers, that they should be screened with upper endoscopy. So compensated advanced chronic liver disease was that concept introduced in the Bovino 6, and again, it's based on transient elastography performed by FibroScan. So patients that had KPA of less than 10 were really not considered to have compensated advanced chronic liver disease or cackled. If they had a stiffness score of greater than 15, then it was suggestive that they had compensated advanced chronic liver disease. The gray zone in between of 10 to 15, is a possibility. So just to summarize again from the Bovino 6, patients that did not require endoscopy were those that had a liver stiffness less than 20 plus the platelet count greater than 150. So Bovino 7 expanded on that and included more detailed information about platelet count. And just in terms of time that we have today, I want to focus on the patients that would benefit most from initiating a non-selective beta blocker like carvedilol. So those that have highly suggestive cackled on elastography scores greater than 15, plus the highlighted platelet counts that we have on the slide. So there's a gap between Bovino 6 and Bovino 7. So we know less than 20, platelet count greater than 150,000. We don't need to scope those patients. If they have a liver stiffness score less than 20, platelet count less than 110,000, we can initiate non-selective beta blockades. But in between less than 20 and 110,000 platelet count and 150,000, we really should be screening those patients with upper endoscopy to identify high-risk varices. So we also should be screening patients that have contraindications to non-selective beta blockers or intolerance. There's also a limitation in that not every center in the United States has access to FibroScan or MRI elastography. This is taken from the EchoSense website, identifying geographically locations across the United States where the FibroScan machine is available, and there are states actually that don't have a registered device. I hope that this map is just lacking an update, but that is what is publicly available on their website. So who deserves a screening upper endoscopy? Patients that have contraindications or intolerance to non-selective beta blockade in patients with compensated advanced chronic liver disease and clinically significant portal hypertension. Those patients that come to us in the office that are already decompensated, not already on non-selective beta blockades, and patients that have liver stiffness less than 20 with a platelet count kind of in that gray zone of 110,000 to 150,000. So we're managing portal hypertension from all different avenues, from a secondary prophylaxis, primary prophylaxis, and now to even prevent hepatic decompensation. And we don't need to be screening every single one of our patients with upper endoscopy. All right, thank you.
All right, I have just a couple more slides from DDW that are some fun slides that are just interesting little tidbits that we learned at DDW. So this was looking at Jazz Bajaj's group. He gave some updates back when I was a fellow working with Gene Chang at U of C, and they were doing microbiome work in IBD. Jazz Bajaj started publishing more and more microbiome stuff in chronic liver disease, and the group has really grown and matured to now where we're seeing significant changes in the microbiome that are actually predictive of liver-related events. So from an outpatient setting, they were noted to be able to identify a microbiome signature that was associated with detection of advanced disease, progression of disease, predicting hospitalization. A big part of this group has been working in hepatic encephalopathy. Obviously, we know that hepatic encephalopathy is something that is very microbiome related, if you will, thus the reason for Xifaxan, as well as one of the actions of lactulose, right, which is to acidify the colon and change the microbiome in that way. But they also noticed that there was a signature that that was unique to the presence of HCC and the response to treatment, which is also very interesting. And then the presence of infections, which is also not that surprising. From an inpatient standpoint, they were able to predict the development of organ failure, prediction of death, infection. So, you know, the microbiome is such an interesting animal, right? And I call it an animal because it is a living, breathing entity. And what we do about these things, right? It's not like everyone's going to do, you know, genome or microbiome sequencing in every single patient that we get here. But the question is, will there be an opportunity to find an easy diagnostic test that uses the microbiome to use these things for predictive analysis? So again, this is the groundwork that's required to do that. So it's interesting and more to come. So this was really interesting. So Elliot Tapper always has amazing stuff about quality of life and just, you know, actually patient-focused care. So he gave a talk about the top 10 considerations for improving quality of life in patients with compensated cirrhosis. So number one on there, near and dear to my heart, is nutrition and exercise. So using a high-protein diet and a late-night snack to prevent the catabolic states of cirrhotic patients. Exercise, again, focusing on improving sarcopenia and weakness with home-based exercises from the website that we talked about yesterday with Cirrhosis Care. They also talked a lot of interesting stuff about Tai Chi, about how that can improve improve mobility, flexibility, as well as strength. The vocal pen score, if you guys aren't using this for your pre-op stratification for cirrhotic patients, this is probably the best one. I always used to use the Mayo score, but since the vocal pen came out, the nice thing about the vocal pen is it breaks down the preoperative mortality based on the type of surgery that's being done. So that's very helpful. PEth testing is available through most commercial labs, so phosphatidylethanol testing. This can usually detect alcohol use and give you a sense of how high the alcohol use is if they give you the quantification. For patients, and the sensitivity assay is probably best in the first like 4 to 6 weeks, but can be up to 2 months. So there's some interesting data that was associated with PEth. So any level above 200 is considered very high risk alcohol use. Anything above 20 is considered more than moderate use. And a single drink doesn't turn your PEth positive, so you need some chronic use for it. But anything above 200 is considered high risk. They found that above 700 is where it's associated with legal issues like DUI, et cetera. So sometimes it's helpful, I have patients that come in with PETs of 1,000 or higher, and just important for them to know that, hey, the amount of alcohol that you're using is associated with X. So especially if they're not in a cirrhotic group. Obviously, if they're cirrhotic, they shouldn't be drinking at all. So effective pharmacotherapy, right? So once you find out that their PET is high, you want to be able to treat them for alcohol use disorder, and that's one of the other slides we'll talk about. So from a retrospective cohort study, they found that use of treatments, medications for treatment of alcohol use disorder was associated with improved survival in patients with alcohol-related cirrhosis. If you know any of the alcoholic hepatitis data, it's not that easy to improve survival because of recidivism, and so this might be the key to that. Preventing decompensation, we just talked about this, randomized studies showing that beta blockers can prevent decompensation. Education, right? So this is a scary diagnosis for patients, and patients, my nurse made a whole booklet about how to dose lactulose, and that gets to number 10, and how to tolerate lactulose, right? So it's a difficult thing for patients to go through, and so having pre-made documentation or education, actually the Cirrhosis Care website is excellent for that as well. And then recognizing under-recognized symptoms in patients with cirrhosis, so sleep dysfunction, sexual dysfunction, muscle cramps, itching, there are therapies for this, right? And so we just have to do a little bit more digging and not just focus on their HCC screening, varicose screening, and ascites, but some of the things that affect their quality of life. And then again, polypharmacy is never good, and with cirrhotic patients, it's really easy to develop polypharmacy, so that's something we want to think about. NSAIDs, right? So NSAIDs can worsen acute kidney injury from renal artery stenosis. Same thing with ACE inhibitors. And then PPIs have been associated with increased rates of infection and decompensation in cirrhotic patients. And then I put good luck at the end of making lactulose more palatable, because you can put it in juice, you can put it in whatever you want to. It's still incredibly sweet. Jamie, I think that as fellows, there was a group of us that tried lactulose, right? Yeah, that was not fun. Okay, so managing alcoholic liver disease is not just about managing liver disease, right? So this was a recent study in the Lancet that showed the effect of a 2008 law in Scotland that showed that setting a minimum price per unit of alcohol allowed for a significant reduction in alcohol sales, but also a reduction in alcohol-related hospitalizations, and alcohol-related deaths decreased by 13%. So if you don't like something, tax it, right? That's the answer. But it shows that public policy can affect these diseases, and especially in the context of the massive increase in alcohol-related morbidity that's occurring post-COVID, it's something to think about. Again, we have to present an updated and consistent message, right, that there is no amount of safe alcohol use. And I think when the CDC comes out with their new guidelines for alcohol use, that will be helpful. More research is needed to understand alcohol-related mortality, right? So certain patients do fine with even heavy alcohol use, certain patients don't. But the important thing is that alcohol-related mortality is at a historic high, despite the fact that overall alcohol use has declined other than outside of COVID. Why is that? I mean, if you ask me, it's because of MASLD, right, or MASH, that as you get that increasing and you combine that with alcohol, the synergistic effects on go. All right, so there are new evidence-based approach for alcohol-associated hepatitis, new criteria that makes it easier to diagnose alcoholic hepatitis. And there's a couple new clinical trials, one from a company called Direct that uses a epigenetic modification that mimics steroid administration without all the steroid side effects. There's interesting data for GCSF. It's interesting, it seems to have an ethnodemographic difference, so the studies in India have really, really amazing outcomes, while the studies in Europe have not been as impressive. So more to come, I think, but hopefully there's newer agents that are coming from multiple companies for alcoholic hepatitis, which is a huge need. Again, transplants for alcoholic liver disease. So if you guys aren't aware of this, the traditional rule was you have to be sober 6 months. So there is a select population that does not need 6 months of sobriety and does not need any sobriety. It's a unique population. It's a low-risk population. I'm not going to get into the details, but just keep that in mind that most transplant centers have criteria for treating acute on chronic alcoholic hepatitis with active alcohol use. And again, we have to be involved. Just like I'm passionate about being involved in the metabolic care of patients with NASH, I think it's also just as important that we as hepatologists and GI doctors that take care of patients with cirrhosis from alcoholic liver disease be involved in their alcohol use disorder. Be familiar with what AA is like. Be familiar with intensive outpatient programs and how you refer patients and do those things. And the study that they talked about was how not great we are at that. So that's something for improvement. There is a lot of new interesting data about eliminating Hep C, not treating Hep C, but truly eliminating it from the population. There's a White House Hep C national elimination plan. There's going to be really critical challenges. Certain the rare Hep C subtypes, like, I don't know, I've never seen genotype 1L or 1P, because it's mostly outside of the US. But patients with decompensated cirrhosis is obviously a group that's difficult, because sometimes if you treat them, they end up with a MELD that just sits in an unacceptable way, but it's not high enough to get a transplant. So you have to be careful with that. Patients with Hep C seem to respond lower, respond less, and so sometimes it's thought that you should treat the Hep C first. And then when do we stop screening them for HCC? So that'll be another challenging question. And then again, I don't need to talk about this because we talked about this in our original talk, so that there is new diagnostic criteria. And yeah, the process of final recommendations is no longer ongoing. It's officially out. All right, now I think we're ready for questions. I don't know.
Well, thank you for the excellent talks. I'm Fadi Antaki from Detroit. As a general gastroenterologist, I end up treating a lot of cirrhotics until they need to be evaluated for transplant. As far as carvedilol goes, when we used to use propranolol, we were aiming for 55 heart rate without lowering the blood pressure. For carvedilol, there's no such goal, right?
Correct.
Is there a dose goal we need to achieve? Do we need to get them to 12.5 or 25 milligram, or is it just as much as they can tolerate?
Yeah, so 12.5 daily dosing, so 6.25 twice daily is the effective dose to reduce HVPG to an acceptable level. Really, when you go beyond that, you risk cardiovascular effects, hypotension, more so than bradycardia. And so really, the only reason that we would drive up the dose of that medication is if the patient had coexisting hypertension. It depends on where the patient is starting at in terms of their baseline blood pressure, but oftentimes I'll start at 3.125 twice daily and then go up to 6.25 twice daily. And if they are stable at that point, then they have reached their acceptable dose. I'm not looking at heart rate, and I don't need to bring them back for screening endoscopy.
As a follow-up, what do you do with the patient hypotensive, maintain imidodrine, try to keep the blood pressure, and really being tapped weekly and so forth? So it's very hard to tolerate beta blocker in those populations.
Yeah, so those patients, unfortunately, probably would not benefit, and they kind of fell outside of the window in the window hypothesis.
That is an important point, though. If they're on midodrine, stop one or the other, right? So it doesn't make sense to do both.
So to clarify, the reasons for doing a FIB-4 assessment on a patient, a BMI of higher than 25 is reason enough to be obtaining a liver panel and checking their FIB-4?
So in the guidelines, it's that you need steatosis, so the diagnosis of steatosis, along with one of those metabolic criteria. And yeah, I thought that was a low threshold of greater than 25, but in the presence of steatosis, the argument is that you have steatosis plus a metabolic comorbidity. So that's why they're saying that you have overweight plus you have steatosis, and that's the etiology. So yeah, it's going to be a lot of people.
It's a pretty low BMI. I mean, that's the overweight range. That's not even
right.
Technically that's not the obesity range.
But you know, interestingly, I mean, obesity by itself is not the only indicator, right? It's not actually that strong of an indicator for having NASH, which is why you want the FIB-4. And honestly, I mean, it's age and it's AST and ALT. It's if you have steatosis on your ultrasound, the likelihood that you're going to check a liver panel at some point is probably pretty high. And if by chance that FIB4 is over 2.67, because we know that, 30% of patients with advanced NASH won't have elevated liver tests, right? So that's kind of the rationale behind, even if you have normal liver tests, but you have a metabolic comorbidity along with obesity, you can capture those patients.
And you brought a good point regarding the Hep C patient. If the patient really decompensated with the Hep C, don't jump to treat those patients. Really, you're doing disfavor for those patients. Those patients need a transplant. And we have been doing lately the patient with the Hep C and decompensated, that give us an opportunity to give him Hep C organ. And sometimes they'll be transplanted earlier, and the treatment post-transplant work, and most of the patients, they'll be cured 3 months post-transplant.
Yeah.
How about for the patient who's clearly not a transplant candidate and decompensates while having Hep C? Would you then treat them? Does that improve their cirrhosis?
So the threshold is usually about a MELD of 25. That's what we thought in terms of, less than that, maybe you can treat it and you can change the natural outcome of the disease. And if they're above 25, that's when you get into this, what we call the MELD purgatory, where you'll continue to have symptoms and not be able to get a transplant. So obviously in the patient that's not getting a transplant, that can't get a transplant and they're decompensating, I think it's a difficult situation because maybe, I guess, you're palliating the symptoms a little bit, but it's not going to fall into an acceptable range where they have no symptoms.
Yeah, I mean, if the patient child C and has Hep C and they're not candidate for transplant, their outcome, unfortunately, is poor. There's not much you could do. Even if you treat the Hep C, the outcome is still poor.
Right. Any other
Thank
questions?
you.
Great, thank you.
Thank you.
Good morning, everybody. We're running a little bit ahead of schedule, so instead of taking a 10-minute break, I think we'd all agree that it'd be nice to just keep moving forward and check out and hit the road. I have the distinct honor of kicking off our motility section. First is going to be Dr. Brian Ginnebaugh, who joined the Henry Ford family from the University of Michigan in 2020. Dr. Ginnebaugh is my partner in crime at Henry Ford and has been really integral to growing and helping to develop some of our multidisciplinary programs with esophageal disorders and gastroparesis. So he'll be giving a talk about, well, I'll let him introduce his title because it's really good. We also have Dr. Faria Ahmad, who is joining us. She received her MD from Michigan State University and is currently a graduating fellow in the gastro department at Sparrow Hospital in Lansing, where she's going to be developing the motility program. So she'll be giving us our DDW updates with Brian as well. So without further ado, Brian.
Good morning, and first off, thank you very much for coming today, and thank you so much to the committee for inviting me to talk. It's an honor to be here with you today. So today, I'm going to try to make constipation a fun and interesting talk, because this is the functional GI section, and we gotta liven things up a little bit. So we're going to talk about chronic constipation, and what I'm going to try to do is go over what to do in clinic to try to help your patients, because this is a very common problem, and this is how I've been approaching it. I do not have any financial disclosures, so we're going to go over definitions of the different types of constipation, the history taking that I feel like is important, how integral the physical exam is, and what diagnostics and what treatment options we have in 2023. So chronic constipation is incredibly prevalent, anywhere between 2 to 40% of the population, with a self-reporting of 28%. It's the most common disorder of gut-brain interaction, and that is the term that we should actually be using when we talk about functional disease. That term is going away with the RUM criteria, and we're talking about these as disorders of gut-brain interaction. And it's actually the most fourth most common GI condition and the sixth most common cause of ED visits in the year of 2016. So very, very prevalent problem. So what is the definition of different types of constipation? So chronic idiopathic constipation, you have less than 3 complete spontaneous bowel movements per week that are noted to be greater than 25% of the time are Bristol 1 or 2. We'll talk about the Bristol scale in just a moment. Sense of incomplete evacuation, a sense of blockage. Patients oftentimes have to use manual maneuvers to have a bowel movement. And then chronic idiopathic constipation does not meet criteria for IBS. So IBS constipation predominant is per the Rome 4 criteria. And so these patients, the major thing that's different for these patients is that they have abdominal pain. So the presence of symptoms for greater than 6 months, abdominal pain accompanies their constipation, and they have a change in frequency or form with their bowel movements as well too. So again, do I really consider them to be two separate things? I think when you're talking about your therapies, these are really, really important, but it's pretty much a spectrum of disease that I almost consider to be a little bit continuous, but certainly can be a very common disorder of gut-brain interaction. So getting the history is most important. Most patients are able to tell you, I'm constipated, but you really kind of got to delve into what that actually means. We actually recommend that we do a stool journal for the patients because recall is not actually that reliable. And you want to do a stool journal off of medications if you can for your patient to really figure out if they actually have constipation or not. If patients are on a lot of medications for any reason whatsoever, 6 or more, they are extremely likely to have that as a factor into their constipation as well too. And what I usually tell my patients in clinic is, in GI we use the rule of 3s. So up to 3 bowel movements a day or up to every 3 days is considered to be within normal, but again, if they're having a bowel movement every 3 days and they're having symptoms, I think that's a different story altogether. And one of the other things we always look for is a history of trauma. A lot of patients have had a history of trauma, abuse, and I feel like it's something that we should be asking our patients more because it really does delve into a lot of their problems as well too that can present later on in life. Alarm symptoms are really, really important to watch out for. So bleeding, weight loss, if it presents over the age of 50. And then you want to think about a family history of celiac disease, IBD, or colon cancer when patients have IBS as well too. And then I think the biggest thing about IBS is it's not just frequency and pain. You want to think about the other symptoms that can be so debilitating for these patients. So it's bloating, it's nausea, it's cramping, stress and flatulence. So all these other things that we need to target, and that's what we need to think about when we talk about our therapies with our patients, because it's not just increasing the number of bowel movements, it's also targeting all of these other symptoms that come along with the disease. So again, we're talking about the Bristol scale. You really want to get your patient to try to do this as much from recall, but if you can do a diary, that's nice. There are some apps that will allow us to do it as well too. But again, constipation is usually Bristol 1, Bristol 2. And patients with IBS-C have it, more than 25% of their bowel movements are IBS 1 or 2. So I was thinking that because it's the Michigan GI Conference, that we can liven up the Bristol scale a little bit, because it's not that cool of a talk. So I decided to make a Michigan version of the Bristol scale. So pictured rocks, which is beautiful, I thought we could think of as Bristol 1, which will probably ruin the experience for anybody who goes there, but that'll be our Bristol 1. The Huron National Forest, these nice, straight, smooth logs we could think about as Bristol 4. Sleeping Bear Dunes, I was thinking about maybe a consistency of a Bristol 6, so I'm going to ruin somebody's afternoon if they're going to go there today. And then lastly, I thought about Bristol 7 as the Huron River, as a brown river that actually flows through the town of Ann Arbor. And I thought what really maybe makes that river brown is this giant toilet bowl of a stadium that is oh so close to Ann Arbor. And if I didn't describe already that I'm actually a Spartan at heart, now you kind of understand where I'm at. So I think one of the most important tools that we have in clinic is actually to do a physical examination, because this will tell us if we need to think about anal rectal manometry. If we don't have anal rectal manometry, oftentimes the rectal examination can be extremely important. And a lot of times you can actually do this without any digital rectal examination at all if the patient doesn't allow you to or has had a history of trauma that would be very troublesome. And so just by looking alone, you can get a lot of information. If you see fissures, hemorrhoids, skin tags, that can be suggestive. But just having the patient do some maneuvers in the left lateral decubitus position actually can be very, very helpful. And I actually learned this from Dr. Saad when I trained with him in Michigan, that just asking the patient to do some maneuvers, you can actually watch the pelvic floor. And if you ask a patient the right way to do the certain maneuvers, you can get a lot of information. So if you tell a patient in the left lateral decubitus position, try to push out as if you're having a bowel movement. And I try not to use the term bear down or squeeze or just terms that maybe the patient doesn't understand. So I say, try to push out stool, and don't be worried if you do. And you can actually watch and see what happens to their pelvic floor. And normally what should happen is the pelvic floor should relax. It should descend about 2 to 3 centimeters, and you actually do see the anal sphincter relax as well too. And so without doing any digital rectal examination whatsoever, you actually get a ton of information. And in patients who can't do this, oftentimes they are clenching their gluteus, or their pelvis actually ascends rather than descends as well too. And so just by watching that gives me a ton of information as to what's going on. If you do the digital rectal examination, and you should, if the patient allows you, you can also tell if there's stool in the stool vault, what the PR angle is as well. And when you ask the patient, you want to say, squeeze on my finger, you can test the anal sphincter competence. And then most importantly, again, try to push out my finger. That's a really important way for them to understand what it is you want them to do and to try to use that maneuver. And so I find that to be really, really helpful. And you can actually feel, again, the pelvis descend, the anal sphincter relax, and the PR angle should increase as it descends as well too. So what else can we do? We should consider colonoscopy if there's alarm symptoms or if the patient is needing screening. We're going to talk about manometry, balloon expulsion testing, and as well as colon transit testing. So colonoscopy for constipation is oftentimes not necessary unless the patient has alarm symptoms or is greater than the age of 45 or family history as well too. Everyone, I think, and I share this too, we have a fear of missing a diagnosis, but the evidence supports that we're not missing it if there's a lack of alarm symptoms. So most commonly in patients with IBS-C, we're seeing hemorrhoids, diverticulosis, we're seeing polyps. But interestingly, in Japan, out of over 4,000 patients, 5 neoplasms were found, but in all those patients, they were at the age where they should have been screened anyway. So I think we have data to support that for constipation alone without alarm symptoms in patients who don't need to be screened by age, we can safely hold off. Anal rectal manometry is available at some centers, not all, and this is why the physical exam is so important if you don't have access or if you would need to refer. Right now what we're using is called the London classification. This kind of came along on the heels of the Chicago classification for esophageal manometry and the Lyon consensus for pH testing as well too. But the patient with a catheter inserted is given a little bit of time to adjust for about 60 seconds. Several squeezes take place to test the competence of the sphincter. You also look for the rare, the rectal anal inhibitory reflex to test for Hirschsprung's disease, which can be a cause of chronic constipation. And then you want to see the push effort as well too. And so what I describe to my patients in clinic before I send them for this, and by the way, I encourage everybody to tell them what you're sending them for because they should at least be informed of what the test entails. But I give them the analogy that oftentimes one of the common causes of constipation is actually the problem is the pelvic floor. And when I start to see patients who are failing multiple therapies, I think the next best test is to order anal rectal manometry because oftentimes it's actually a defecatory disorder that can be causing their non-response to medications. And so I give them a toothpaste analogy. Some of you probably know this, but I tell them that having a bowel movement is a lot like getting toothpaste out of the tube. If you have kids and it's folded, you got to straighten it out, so that's the PR angle increasing. You need to squeeze on the tube of toothpaste, and so that's actually squeezing on the rectum, and the cap has to come off, which is the anal muscle relaxing. And when I explain that to patients in clinic, they understand why I'm ordering this testing and what it is that we're actually looking for. Balloon expulsion testing can be done with Foley catheters, latex balloons, and then there's also commercially available balloons as well too, which are more expensive. Patients should be given privacy on a commode after this is inserted into their rectum with about 50 cc's of room temperature water. And if they cannot expel it within 1 to 2 minutes, that's an abnormal expulsion time. In order to have a defecatory disorder diagnosed, you have to have 2 abnormal tests, so the balloon expulsion test along with manometry. And if you don't, if they're discordant, the next best test to order would be a defecography to see if that shows signs of a pelvic floor disorder as well too. This is more of a busy slide, but this is using the London classification that we're now using to diagnose this. But really what you want to know with the London classification and what everyone who refers wants to know is, what do I do with the patient based on the results? And I think that's the most important thing. So Hirschsprung's, while we talk about it, is oftentimes, no pun intended, rare to see. What we can also diagnose anal hyper or hypotension, dyssynergia, which I think is probably the more common thing that we're looking for. But I think it's also noted that anal hypotension or rectal hypotension is incredibly common as well too. And this is where the patient basically loses the call to have a bowel movement. So what I always tell my patients is when you get the call to have a bowel movement, when you're hearing that, listen to it and go to the bathroom. Don't continue what you're doing and go to it later, because you can lose that urge over time and your body gets used to it. And so I think that that's incredibly important as well too. And then physical therapy is incredibly important to get these patients to a trained pelvic floor physical therapist. And when I've always asked patients who said, hey, I tried pelvic floor therapy and it didn't work, I say, what did you do? What did they do when you went there? Because I think that is really, really telling. I've had some patients tell me they worked on my shoulder. Well, I know you had shoulder surgery, but that's not going to help our problem. Some patients are told to just do Kegels or they're just doing abdominal massage, but what they really need is true catheter-based biofeedback therapy if they have dyssynergia, to give them real-time information as to basically retrain themselves on how to have a bowel movement. And then balloon training, if the patient has hypotension, is incredibly important as well too. So we have to find the right physical therapist, have to make the recommendation as to what the appropriate therapy is, and this is how we're going to end up helping the patient as well too. Randomized trials show that about 60 to 80% improvement, low side effect rate of any physical therapy whatsoever, and it's better than placebo, Miralax, sham biofeedback, or just pelvic floor exercises alone. So I encourage you to ask your patients, when you went to physical therapy, what did you do? Because I find a ton of information in that as well too. Patients who have a higher likelihood to respond include patients that are using digital maneuvers. They fail the balloon expulsion test. And this is basically all the major societies recommend is this first-line intervention. Transit testing, I personally don't find to be that beneficial. And the reason being, if it's normal, I think it's helpful. And if it's normal, you would always want to never send your patient for surgery. But slow transit and outlet obstruction can actually mimic each other. Because what can happen is in panel C, where you see that all the rings are basically stacked up, that can be a sign of a defecatory disorder. But over time, the rectum is basically overloaded, and it tells the rest of the colon, hey, wait, I've got no more room. Slow down. You need to stop moving so fast. And so you can morph from C to B as well, too. And so I really feel that although this sometimes can be helpful, again, I still feel strongly that the next best test, rather than doing transit testing, would be is to do anal rectum manometry. So in terms of treatment, we want to think about what treatments we're going to target for our patients, what they've already tried, and we also want to make sure that we're targeting the global symptoms that come along with IBS and this disorder of gut-brain interaction, because simply increasing the number of bowel movements doesn't always improve the problem, unless it's just pure constipation without any other symptoms as well too. So we have osmotic laxatives, and probably the best being PEG 3350 or Miralax. There's some stimulant laxatives as well too. Some of the societies do recommend them as well, and bisacodyl specifically for rescue therapy. There was recently a brand new guideline released from both the AGA and ACG on management of chronic constipation, which is pretty helpful, but a lot of the societies overlap in some of their guidelines, so this was kind of unique. Linaclotide, also known as Linzess, we're recommending for IBS-C, and we're recommending for chronic idiopathic constipation. It will increase complete spontaneous bowel movements. It's probably been out there the longest of all the prescription ones, that and Amitiza. But the big difference in these medications, again, is that they're not just going to increase the number of bowel movements. They are going to work in more of a neuromodulatory effect, and they're really going to help out the global symptoms that come along with IBS, including bloating, abdominal pain, etc. that purely something like Miralax is not going to do. So this is what we need to think about when we start treating our patients. Lubiprostone, also known as Amitiza, is a BID dosing, both 8 micrograms BID and 24 micrograms BID. Some doses of these medications are approved for chronic idiopathic constipation. Some are approved for IBS-C. On a personal note, I actually write for both when I prescribe these so that I can kind of dose escalate up and down without changing all the diagnosis. And truthfully, I feel like it's more of a spectrum of the disease in my practice. Plecanatide, also known as Trulance, 3 milligrams a day, FDA approved for chronic idiopathic constipation and IBS-C. And then lastly, one of the newer ones that's out, this came out in 2019, is tenapanor. And this is a small molecule inhibitor of the sodium hydrogen exchanger, and it's 50 milligrams twice daily. So if you haven't heard about this or this is newer information, this came out in 2019, FDA approved. And I have found that it has been an effective addition to my practice as well too. I think some of the things that are probably going to be coming down the pipeline is maybe more getting dual mechanism or prescribing 2 medications for patients who are refractory, so that you can target 2 mechanisms as well too. Lastly, and this will be in my next talk, we're going to be talking about a lot of patients don't want to be on medications. A lot of my patients say, what can I do about diet? And there's a lot of dietary therapies, or I don't like the side effects of these medications. And so what has come out in the last about year and a half is a vibrating capsule for the treatment of chronic constipation. And I'm going to talk about that a little bit more in my next talk as we review DDW abstracts. So take-home points for constipation. It's an extremely prevalent problem, and no matter what field of GI or primary care that you're in, you're going to see a lot of these patients. I think the history and the physical exam is incredibly important. Colonoscopy is rarely indicated purely for constipation, but again, watch for red flag symptoms and make sure your patient is, if they need to be screened based on age, then they should be screened as well too. And then I feel in refractory cases that anal rectal manometry with balloon expulsion testing is the next best test for patients who have refractory constipation for reasons we talked about earlier. And then physical therapy, again, very, very important. And ask your patient what they did, what kind of physical therapy they had. And there are a lot of resources to get these patients to a physical therapist around the state of Michigan as well too. Thanks so much for inviting me.
All right, good morning, everyone. So we just got finished talking about pooping, so now we're going to talk about puking. So very exciting, you guys. Alrighty, let's see. I don't have any disclosures. So just to kind of understand where we're going to be going, we're going to be talking about a new diagnostic modality that can help assist us in our nausea, vomiting, dyspeptic patients. And then we're going to have a little bit of a basic science update, so I hope I don't put you to sleep at the end. Alrighty, so one of the challenges that we have when we're dealing with patients with vomiting, nausea, dyspeptic syndromes is that there's significant overlap between functional dyspepsia and gastroparesis when it comes to both clinical presentation and also in terms of the pathophysiology. Part of it is because we honestly don't really know kind of how these conditions evolve. What we do sort of know, there we go, is that FD has maybe a primary sensory component, that's the primary sensory dysfunction, while GP has more of a motor dysfunction or motor component. Currently, the one main modality that we have to kind of help us in supposedly differentiating between these two is gastric emptying scintigraphy. Unfortunately, this has pretty significant clinical limitations. So this is a study that was done by Camarelli's group where they were trying to basically understand what is normal gastric emptying. And even in this normal population, they found that there was 23.8% intra-subject variability on repeat GS testing. So there were some questions about the reliability of this test in being able to be making diagnostic decisions. And then kind of the nail in the coffin was this most recent study that was done in 2021 where they had patients with GP and FD based upon the gastric emptying study and Rome 4 criteria. They retested them in 48 weeks, and they ended up having reclassification. This reclassification was not associated with any change in symptoms, nor was it changed in any amounts of the interstitial cells of Cajal, so there was no pathophysiologic change that was detected. The GS was also profoundly found to be very poor at detecting neuromuscular changes for patients who had neuromuscular disease in that study. The authors made this statement: gastric emptying does not reliably capture the pathophysiology of clinical symptoms in either condition. So, what do we have? So this was recently FDA approved gastric allometry, so it's pretty much the same procedure as gastric scintigraphy. It is basically a belly band that non-invasively evaluates gastric myoelectrical activity and then correlates that data with symptoms that are reported at the time that they occur. So for the first 30 minutes, they kind of get baseline activity, then they give you the egg beater equivalent meal after 30 minutes, and then in that 4-hour postprandial period, patients basically report symptoms in real time as they're occurring. From that, in the interest of time, I'm not going to go into too much detail about the actual data points that are kind of extracted from this, but what you get is you get this rhythm with many different data points in terms of describing the gastric activity. So what the authors have identified in evaluating tons of these different profiles is they've classified spectral phenotypes and symptom phenotypes. So for the spectral phenotypes, these are basically based upon some of the features of their response. They've correlated them to certain conditions. So neuromuscular disease, muscular dystrophy, those types of things has been correlated to that number 1 neuromuscular profile. The high frequency profile is more so correlate with neuropathy. So vagotomy, diabetic neuropathy, this is the type of profile they tend to have. This high amplitude profile, number 3, is typically seen in patients that might have like a gastric outlet obstruction of some sort. And then if they have normal gastric activity and they still are symptomatic, they then have this other classification for symptom phenotypes. What these symptom phenotypes are patients with normal gastric activity, and they have symptoms that in some way are related to the gastric activity changes, even though the changes are within normal variation. So in the number 6, that post-gastric profile, you have patients where they start actually being symptomatic after completion of gastric activity. In those patients, they tend to find biliary or small bowel causes that they're trying to identify. For the sensomotor profile, these are patients where even though the changes are within normal variation, you can predict when they're going to have a symptom because those changes are associated with a symptom. The continuous profile is the profile that there is completely no association between any changes in myoelectrical activity with the patient's symptoms. So this first abstract is basically looking at the utility of this technology when you compare it to gastric emptying scintigraphy. So the primary questions that they're asking are, 1, does gastric allometry phenotyping improve the yield of detection for abnormalities compared to GS alone? Are we able to classify and identify more patients and be able to have clinically useful groups? Do these phenotypes correlate with behavioral variables? Do these phenotypes actually reflect the symptom burden and the quality of life impairment that we're trying to help them address? It was a pretty small population, but they took mostly females. They're obviously not from Michigan because their median BMI was 24. But they had chronic duodenal symptoms, no history of major gastric surgery. And it was mostly split between people who were kind of chronic nausea, vomiting, plus or minus FD based upon the Rome 4 criteria. And then there were some FD, some gastroparesis, and then some that were unclassified. Prior to testing, they obtained some psychometric variables, so quality of life assessments, symptom burden, psychological distress. They then did that standardized 4.5-hour study with the egg beater meal, and they simultaneously did a scintigraphic study, because these things can actually be done simultaneously since the procedure is largely the same. The primary outcome were diagnostic yields of gastric alimentary phenotyping and GES, and then correlation between diagnosis, symptom burden, quality of life, and psychological profiles. So with gastric alimentary, 62.7% of the patients in this population were able to be placed into different subgroups. And only 22.7% were able to be identified as abnormal with GES. So this was a 40% increase in yield. It was statistically significant. Interestingly, there was no correlation between GES and GA spectral analysis, which spectral analysis is that myoelectrical activity readings, but there was some classification overlap. About 13.3% identified the same population when looking at these two tests. So this kind of brings to light the fact that, one, how the stomach works is very complicated, and two, these tests are probably testing different parts of the same thing, so they're probably testing different parts of the same variable, and they might be complementary in practice versus exclusive. When you looked at Rome-4 diagnosis, classification, and delayed gastric emptying, the studies did not correlate with any symptom burden. They did not correlate with anxiety, depression, or quality of life, which is what we kind of already know. But all of the GA phenotypes correlated with symptom burden as measured by the PAGI SYM, and spectral abnormalities and the continuous phenotype were the ones with the strongest correlations. The continuous phenotype was the one that had the greatest symptom burden that was detected, and of the symptom phenotypes, obviously, it was significantly, actually, statistically significantly different from even the sensory-motor profile. In terms of anxiety, anybody with spectral abnormalities, so anybody who had a spectral phenotype, had a significant anxiety scoring. So it was correlated with patients' feelings of distress and anxiety. The continuous phenotype and the sensory-motor phenotype were also correlated with anxiety, but once again, the thing that had the strongest correlation was the continuous phenotype. I don't know if you're seeing a pattern here. In terms of quality of life, of all of the phenotypes, the continuous phenotype had the greatest impairment of quality of life, and this was even statistically significantly different from the other symptom phenotype of the sensory-motor profile. So kind of key points for this abstract. The GES findings are labile, and they do not reliably reflect neuromuscular pathophysiology. They do not reliably correlate with symptom burden or psychological burden, so we don't really know what they mean clinically. GA and GES evaluate different, though likely related, domains of gastroduodenal function. GA phenotyping detects significantly more abnormalities compared to GES. GA spectral analysis allows for improved detection of gastroduodenal neuromuscular pathology, and that these phenotypes correlate with patient-reported symptom burden. The continuous phenotype and the abnormal spectral phenotypes are the most correlated with anxiety, and the continuous phenotype is the one where you have patients who are the most anxious. The second abstract, which is related, is like, okay, great, we've decided that this has some relevance in terms of what my patients are seeing and being able to identify them as in different classes. What do we do with this clinically? Can we clinically apply this, and does it actually do anything in improving our clinical practice? So that's kind of what they're looking at the second study, is that they were saying, does this test actually lead to meaningful change in patient outcomes? And in terms of a quality improvement or hospital utilization standpoint, does it actually lead to a decrease in resources being utilized by the hospital system? So just to briefly go over the workflow that they used. So they kind of combined the neuropathic and the neuromuscular profiles as just gastric neuromuscular duodenal disorder. Patients who were identified as that were treated per gastroparesis guidelines. If they had a high amplitude activity, that was the one that I mentioned before, that often is, they had found with gastric outlet types of etiologies, they had them do an EGD to evaluate or exclude for distal obstruction, and then a gastric emptying test. If it was slow, they would do prokinetics, and plus or minus these patients might benefit from pyloric therapy. If they had a normal spectral analysis and they didn't have any symptoms that would suggest a gastric emptying study might be useful, then they kind of managed them by the symptom profile. If they had a G test and it was not slow, then they would also be managed with the symptom phenotype profiles. So sensory-motor profile, they treat it like postprandial distress syndrome. Continuous profile, they treat it as epigastric pain syndrome. And the postgastric profile, they evaluated for small bowel and biliary causes. So similar format as the other study, except these patients were significantly sicker. These are patients who've had multiple different types of assessments. 70% had prior GET testing. Some of them were on enteroparental nutrition. So these was a very debilitated population. They looked at the institution that had the most patients that presented, and they obtained hospital utilization data from that center. They the independent assessors basically reviewed whether or not there was a change in diagnosis or change in management, and then they also obtained some healthcare utilization variables kind of listed there. Their primary outcomes were kind of frequency of positive management impact and impact on healthcare system. So in 40% of the patients, there was a change in diagnosis. In 78% of patients, there was a change in management. When you look at the healthcare outcomes, diagnostic test utilization significantly decreased on all different modalities. In hospital and clinic utilization, inpatient stay nearly went down to zero after initiation of this model. Clinic visits was the only thing that was statistically non-significant when you look at resource utilization. In terms of money, there was significant cost reductions, and there was a savings about $5,400 in US money, at least, per patient per year. So key points, GA phenotyping results in changes in diagnosis and management that are associated with decreased healthcare system utilization. It potentially also reduces the cost of the overall healthcare system. They didn't take into consideration the cost of the device because it is a newer device, and also it's not really sure how this would translate into the American system, which is why it was a potential reduction. So this is the fun one. This is an abstract that was done by Gilberson's group at Michigan State University, looking at early life adversity and how that might impact enteric glia. So I'll just briefly mention enteric glia. I won't get into too much detail, I promise. So enteric glia is basically, they're like the astrocytes of our gut. They manage our enteric neural network. They tell everyone what to do. They coordinate motility. They manage enteric immunocompetence. And in the basic science world, theoretically, this idea that enteric glia manage neuronal pruning and neuroplasticity might be actually, they're thinking, the cause of a lot of the organic and functional diseases that we are trying to treat. So as I mentioned, they're essential for gut integrity. So this was a study where basically they had selective ablation of enteric glial cells, and it led to necrotizing enterocolitis, and so they died within 4 days, the mice did. When they had partial ablation of the enteric glia, you were able to detect significant intestinal permeability, and also resulted in a colitis-type picture. From a motility standpoint, these kind of studies had demonstrated that enteric glia were the only things that were actually required in order to be able to induce a contraction of the bowel. So you didn't need to stimulate the nerves, you need to do anything. All you need to do is excite the glial nerves, and they were able to lead to a contraction. That was true both in the ileum and in the colon. Changes in excitation also led to changes in colonic and ileal transit. So what they kind of looked at is they were saying, okay, well, if we put early life stressors, how does this affect how these glial cells actually have gene expression? So does constant exposure to early life adversity induce intestinal dysfunction? And does consistent exposure induce any changes in glial genetic expression? So they did a neonatal maternal separation model, which is basically where they separate the pups from the mom for 3 hours every single day from day 1 of birth, and then they wean them, separate them permanently from the mom early than what they would usually do, and they compared that to those that were handled normally. What they found is that in male mice, there was an increase in visceral hypersensitivity when they evaluate them at 16 weeks. And in terms of transit time, for motility for both sexes decreased. They did the same thing for the second study, but this time they actually tagged the enteric glial cells so they'd be able to extract mRNA from them to be able to evaluate genetic expression. When they looked at genetic expression, they found that there were sex differences between male and female, non-traumatized male and female genetic expression in enteric glial cells. And when you looked at the traumatized male, the genetic signature of the traumatized male's enteric glia more closely was similar to the non-traumatized female enteric glial expression, more so than the normal males. So there was this idea that adversity actually feminized the genetic signature of the enteric glia in males. So something interesting for an implication here, this makes us wonder whether or not maybe in looking at sex differences between men and women, maybe some of it can be accounted for that maybe males use like this kind of two-hit where they have one stimuli that feminizes the colon or feminizes the gut, and maybe another hit that leads to IBS, whereas women maybe only require one. Now, mind you, extrapolating from animal models, but something interesting to think about. So, key points, that early life adversity basically seems to remove these sex-specific differences in enteric glial expression in male mice, and also induces visceral hypersensitivity in male mice and decreases motility of both sexes of mice. All right, thank you so much.
Okay, so I'm going to talk about some DDW updates as well. I've found sometimes that DDW can be a little bit overwhelming, so I'm thankful for talks like this that can give us some take-home points. And my goal is to go over 3 things that we're going to talk about today that hopefully you can integrate into clinical practice. So the 3 abstracts that I selected included the colonic biological clock and the time of bowel movements with a vibrating capsule for chronic idiopathic constipation. We're going to talk about a trial called the TANDEM trial, which actually looks at the Mediterranean diet for IBS. And then we're also going to look at gut-directed hypnotherapy versus muscle relaxation for patients as well. So the vibrating capsule, I first heard about this at DDW in 2022 when Dr. Rao presented it. And that's kind of when my patients started asking about it right away. And for the next year, I've gotten several messages about what is the capsule, and when can I start taking it. And then just recently published in Gastro was their phase 3 trial. So like we talked about earlier, despite advances, there's a lot of patients who don't respond to therapy, don't want to be on therapy, dietary therapy might not be working, and chronic constipation is a huge burden. So to avoid side effects, the cost, patients just don't want to be on medication sometimes, and thankfully there are going to be some options that are going to help them out, because about 50% of patients are not satisfied with their therapy for constipation. And stimulation of the gut has actually been tried previously. They've done transabdominal electrical stimulation, which did not work, external kneading forces of the abdomen for constipation, which have not worked. And then eventually, I believe, whole body vibration has actually been trialed for chronic constipation as well too, and it has not been proven effective. But the hypothesis here is that mechanically stimulating the colon will change the circadian rhythm, increase colonic contractile activity, and so out comes this pill which vibrates, and it was done over an 8-week trial. So the patient, for 5 out of 7 days of the week, takes this vibrating capsule, and they take it around 8 or 9 p.m. at night, and 14 hours later, the capsule turns on. And for 2 hours, this capsule is actually active. It vibrates for 3 seconds on and 16 seconds off. And again, 5 days out of a 7-day week, the patient is told to take this pill. This was actually done over 95 centers, placebo-controlled. They actually started with 3 arms, which we'll talk about in just a second. The 3 arms were placebo, and then the vibration timing just changed. One started at 6 a.m., and then the other one started at 12 p.m. So just trying to figure out which one was going to be more effective for patients as well too. Adults 22 years or older with chronic idiopathic constipation according to Rome 3. And these patients were included if they had not responded to laxatives for at least a month, between 1 to 2.5 spontaneous bowel movements per week, and they were up to date with colorectal cancer screening and did not have any alarm findings. These are the exclusions for this, which I think is important because when we want to start our patients on this, which I think is eventually going to be more popular down the pipeline, we need to think about, can we start it? So patients who have complicated or obstructing diverticular disease should not do it. Not all diverticular disease, just patients who have had complications. Patients with obstruction, obviously, not a good idea. Patients with IBD are excluded, at least in the study, or patients who have a GI malignancy. And then gastroparesis, Zenker's, dysphagia, stricture, anything that's going to increase the risk of basically the capsule not moving forward. Patients with pelvic floor dysfunction, megarectum, or patients who are pregnant or with a significant systemic illness were excluded in the trial. The patients basically had they were looked at for 2 weeks and said, do you meet criteria or not? There was basically a run-in. And then if they met the eligibility after that 2-week e-diary, they were randomized to either the vibrating capsule or placebo. And initially they did 3 phases, placebo versus mode 1 versus mode 2. And again, mode 1 versus mode 2 just differed in where the capsule actually turned on. And so what they actually found out is that mode 1 was actually the preferred one, and the mode 2 patients were actually excluded in the final analysis as well too. So they did this for 8 weeks. They screened about 900 patients, and in each of the 2 arms, so mode 1 and placebo, you had about 140 patients in each arm who actually completed the study, so pretty good data. And what they were looking at is, did this increase complete spontaneous bowel movements over the period of the week? So the patients who had at least one was one of the primary endpoints, and it was statistically significant, 22 versus 39% in patients who were on the capsule. And actually, 22% of patients versus 11 had actually increased by 2 complete spontaneous bowel movements per week. So it did show that it was statistically significant for their primary outcome, which is increasing complete spontaneous bowel movements. So the vibrating capsule proved to be safe, and it was pretty much one of the first in class non-pharmacologic for the treatment of chronic constipation. 18 patients, though, did report the side effect of vibration, and I think this is the difficulty with interpreting some of the events, is the fact that the capsule is vibrating inside you. Although only 18 said they sensed it, the fact that it's on for 2 hours every time you take it for a total of 8 weeks, I would be hard-pressed to find that you can't feel it somewhat. And so that's the only question I have with that trial. And then what was presented this year at DDW is the circadian rhythm of bowel movements as well too, and patients specifically who had no complete spontaneous bowel movements throughout the week, which means they had to use a laxative or use maneuvers to have a bowel movement. Those patients specifically responded really, really well to the capsule. And the takeaway here is that these bowel movements are actually happening much later in the day. So for our patients who maybe take a medication early in the morning and have to be on the toilet and they're missing out on work and that's not working for them, it's not really an ideal situation. But maybe if you're a surgeon, you're in the operating room for 8 hours all day, this might be a better option for you because the action's going to take place later in the day. And so for a lifestyle, no side effects, I think it's actually a pretty cool mechanism, and I think we're going to see a lot more down the pipeline as well too. The second thing I want to talk about is diet for IBS non-C. So low FODMAP has been out for a while now. Many studies have proven its efficacy, but it can be a little bit difficult for patients to adhere to. First off, really working with a dietitian, which can be rare, is very, very clinically important. It's tough to do on your own, and we need to make sure that we're doing it right for our patients. So if we do initiate, I try to have them see a dietitian, and if it doesn't work after 4 weeks, you should abandon it altogether. But if it does work after 4 weeks, then where the dietitian comes in is they're going to start to reintroduce foods and personalize the low FODMAP diet because it's extremely, extremely restrictive. And probably some of the things that we're really missing in our patients is avoidant restrictive food intake disorders, or ARFID. And so I think that the low FODMAP diet can sometimes exacerbate things in those situations. And so it can be a little bit more frustrating for the patient, the clinician, and the dietitian as well too. So the TANDEM trial was done in Australia, and this was presented this year at DDW. And the thought was that not only could the diet maybe be simpler, but could it also affect the patient's anxiety and other symptoms as well too, because of how coexistent these symptoms are with IBS as well too. So a Mediterranean diet, which we all know, rich in fruits, vegetables, grains, olive oil, really healthy diet, and it can lead to there's been studies that show that it leads to positive changes in the microbiome. And some trials have shown its antidepressant effects as well too. So pretty good option for some of our patients. So the trial was aimed to see, does the Mediterranean diet work in patients who have IBS? And so they did a randomized trial over 6 weeks in adults who had IBS. And one arm, the patients were given individualized device, reintroduced FODMAPs, and they were actually given a food basket that they could eat and select those foods from, and that was the main intervention arm. The control arm, they got some what was labeled as identical research activities to the Mediterranean diet, but they didn't get advice from a dietitian. They were encouraged to just stay on their usual diet. And then they got the food, but they got the food after the study was done, so I think everything, it worked fair, but again, they were not given the food basket until the end of the study as well too. And what they really wanted to see was, does this alter the microbiome? Does it change your symptoms at all? And is it actually easy to adhere to? And that's what they found, that it's a lot easier for patients to adhere to. Obviously, if you have a food basket being delivered to you and that's what you select from, that makes it easy. But again, between the two groups, there were no difference in the overall intake of FODMAPs. Patients had improved pain if they were on the Mediterranean diet. No alterations, there were no alterations in the microbiome overall. They collected stool samples after the study as well too. And depressive symptoms actually were better in the patients who were on the Mediterranean diet. So I think a take-home point would be, in patients who either don't respond to the low FODMAP diet or it can be very restrictive, we should be thinking about Mediterranean diet going forward, and I think there's going to be more trials up ahead. And then lastly, from Dr. Chase group at U of M, randomized trial that showed, that compared gut-directed hypnotherapy from a digital format to muscle relaxation for patients with IBS. And I think what if we haven't talked about it already, is that actually seeing a GI behavioral health psychologist for your disorder of gut-brain interaction can be very, very difficult. We have 4 in the state, 3 are at U of M, 1's at Henry Ford, and they only come from internal referrals. So with the digital health era being so prevalent, what's been really nice is now there's FDA-approved therapies for both cognitive behavioral therapy and gut-directed hypnotherapy that have come out. And so because patients are really not satisfied with their treatment of IBS, adding either gut-directed hypnotherapy or CBT can be really, really, really beneficial. And again, really low side effects for these. You're working one-on-one with without any medications as well too. And the number needed to treat for patients with IBS is super, super low, between 4 to 6. So the other control arm that they did in this was actually muscle relaxation, and there has been some benefit that has shown that muscle relaxation can also be beneficial for patients as well too. So the 2 arms were gut-directed hypnotherapy, and the second arm was just muscle relaxation, and both were from a digital perspective. Patients who were with IBS were included in the study. It was done over 12 weeks, and I think what they were really looking for is, does your pain symptom improve afterwards? Secondary endpoints were stool consistency, quality of life, and overall the patient satisfaction as well too. And just to kind of go over the results, I'm going to skip forward because the 2 groups were equal. Abdominal pain was post-treatment was improved to 30% in patients who were on the gut-directed hypnotherapy. But interestingly, 27% of patients improved with muscle relaxation. But during treatment, patients had a lot more improvement in their pain if they were on the gut-directed hypnotherapy. Key secondary endpoints for this, stool consistency, relatively equal in both groups, both with IBS-C and D. And then overall adequate relief was pretty high in both groups. So both gut-directed hypnotherapy and muscle relaxation actually worked. And I think this begs the question of, is muscle relaxation therapy something we should also be thinking about as well too, because it seems to be pretty effective for these patients and might be another option for us in the future as well too. So take-home points, we can and will be able to soon be using a vibrating capsule for the treatment of chronic constipation. Mediterranean diet might be a very new, or not new, but very effective therapy for patients with IBS non-C. And then gut-directed hypnotherapy and potentially muscle relaxation will be helpful for our patients with IBS who may or not be able to see a GI behavioral health psychologist. So with that, I will close, and thank you guys so much for your attention.
Thank you so much to our speakers. We'll open up the floor to any questions, and I've got a few if nobody has a burning question. So I guess I'll start. Brian, can you comment a little bit upon what patients you would use prucalopride for motegrity?
So prucalopride at a dose of 1 to 2 milligrams a day is FDA approved for chronic idiopathic constipation. And I have used it for patients with constipation. It can work very well. The cool thing about it in the serotonergic pathway is it works on whole gut motility as well too, from the esophagus on down. So for patients who have potentially upper GI symptoms as well too, whether that be functional dyspepsia or gastroparesis, it's a really nice option as well too. From a perspective of treating gastroparesis a lot, I tend to ask patients if they're constipated, and then I prescribe this for chronic idiopathic constipation because of what we talked about earlier with Dr. Kanukin's talk this morning about how to get things approved. Writing for the correct diagnosis is so important, and because it's FDA approved for chronic idiopathic constipation, that's what I write it for, even if I'm trying to use it for gastroparesis as well.
Completely agree. That's what that's the exact medication I was thinking about during her talk, because you have to list everything else they've failed, including fiber and lactulose. Any other questions from the crowd?
No.
Hi. Sorry, quick question. Thank you both so much for the fantastic presentations. My question specifically was about the capsule study. I wonder, did they mention any explanation for how they chose the 3 seconds on, 16 seconds off for the 2 hours?
I don't know if they've done earlier trials as to why it was 3 on, 16 off. They didn't really. I don't think they went into that in the Gastro Journal article. But I think it's a very excellent question and probably has an adequate explanation that I actually don't know.
And I guess theoretically, though, the administration at bed and all that, it might have some explanation with the circadian rhythms. Was that kind of the takeaway regarding taking it at night and that sort of?
Yeah, so this is to try to augment the circadian rhythm that can come along with bowel movements as well too. And a lot of patients, the circadian rhythm we think is probably earlier in the morning. But some patients who have chronic idiopathic constipation, that rhythm actually might be shifted to the evening or afternoon. And so the thought is that augmenting it at that time is what helps these patients with their constipation.
Thank you.
So, one question and then one comment. With the vibrating capsule, did they follow them after the 8 weeks of therapy? So did they discontinue the capsule and then follow their symptoms following discontinuation of the capsule?
Thank you for your question. I believe they did, but I don't think they report it as one of their primary outcomes, because I think everyone's question is, yes, you can take this vibrating capsule 5 days out of 7 days a week. Are you going to have to continue it forever?
Right.
And my sense is probably yes, because as soon as you remove the stimulus, I think that the effect is going to go away as well too.
Possibly, yeah. That'll probably be something that comes down the road.
And possibly not.
The other point to make is, and it's important to realize this, they excluded folks with pelvic floor dyssynergia. So it is important that you still evaluate your patient for pelvic floor dyssynergia, which represents a significant portion of your refractory constipation patient. So you should do that before you embark upon, this vibrating capsule.
Exactly, and again, I think that goes back to when your patients are failing multiple either over-the-counter therapies, prescription therapies, the next best test being the pelvic floor. So thank you.
So by the time we see patients with constipation, they've usually tried the over-the-counter medications, and then they come to us and we are evaluating them for medication-wise linaclotide or lubiprostone or something. But the new ACG-AGA guidelines recommended trials, among other things, of magnesium products. I don't know if you guys saw that. I've never personally prescribed magnesium for constipation, but it sounds very appealing as safe, relatively cheap, old-fashioned medication. But I don't think any PCP has ever heard of this. So is that something you guys are thinking about maybe introducing as before the first line?
So I personally have used it as more of a rescue therapy, and especially in patients who have pelvic floor disorders who actually don't respond to pelvic floor therapy. magnesium products can actually be beneficial. Granted, there can be a shortage at times. I think there has been recently. But I think the thing to take home from that is that these guidelines came out for chronic idiopathic constipation specifically. And I don't know if it was for IBS, but again, I think it goes back to targeting the gut-brain axis as well too, the neuromodulation that comes with the prescription, because that is not happening if you simply increase the number of bowel movements. You have to think about the pathway of neuromodulation. Thank you.
So just so that I understand, I wasn't familiar with this gut alimentary, but it seemed like the most common finding was that there was no correlation between the myoelectric activity and symptoms. Is that correct?
No, so that was just one of the profiles. The continuous profile was the one where there was no correlation between myoelectric activity and symptoms. So,
But that was the most common one, wasn't it?
it wasn't the most common. It was the one that had the most severity. So they didn't actually tell me what the frequencies was, either in the data, in the presentation they gave at DDW, or in the data that was provided from the accepted paper that I had read, in terms of the frequencies of each profiles. Other problems with the, concerns that I have is that the validation of the profiles themselves in terms of neuromuscular outlet obstruction, those type of things, I wasn't able to find that data. So those are a couple of things that I'm wanting to know more about, and I was told that they are writing up a paper about that. So
Okay, because I was just, one of the things we understand about gastric emptying is it doesn't correlate with symptoms.
Yeah.
And I'm wondering if this is just telling us the same thing, just using a different biomarker.
yeah, so I think they're actually testing different things of the same problem. So I didn't go into the interpretation of the waveform, but there's a summary average amplitude parameter that they have that I have a feeling will probably correlate with gastric emptying results. But the profile was able to identify at least patients who either had electrical activity that was predictive of symptoms, or people who had electrical activity that indicated a organic problem that needed to be investigated. And so I thought that was more so the benefit of the study, and also figure out exactly who that population is that's going to most benefit from, the initial, consult to CBT and starting them on disipramine, immediately, in terms of the algorithm they provided. So I thought it was helpful in that respect.
And I noticed the patients were pretty lean that had that. So does it work in Americans?
Yeah, so I have no idea. It works in Australians and New Zealanders. So the QE, that's all I know right now. But I do think it's something that's exciting, that if it has efficacy in our population and the phenotypes have been validated in a way that I feel comfortable with, that I think it can be like very transformative for the management of functional dyspepsia and gastroparesis.
I have a couple of comments. Number one, I totally take offense to the term feminizing of the colon. It'd be interesting to see if the authors were male or females. Number two, so I have found myself, Brian, using colon transit tests to assess for overflow diarrhea, because I just saw a patient on Thursday, actually, who is reporting 4 to 5 episodes of small volume diarrhea every single day. And all of her imaging that I reviewed just showed colon that was like packed full of stool. So I think that there is some kind of other applicabilities to colon transit tests. So I do find myself still using it. Another thing is I do love the London classification. I think it has made reading and interpreting anorectal manometry very easy. Basically, the 4 different subtypes that Brian talked about, assessing for areflexia, the integrity of the anal sphincter, rectal hypersensitivity, hypersensitivity, and then assessing for pelvic dyssynergia. But when I'm reading an anorectal manometry, I always have the Rao classification in the back of my head, because I think that there is still a lot of value to identifying somebody as a type 4, which is kind of an inability of the rectum to squeeze and an incompetence of the anal sphincter to relax, in the sense that there's either incomplete or absent relaxation. So that subtype in which you kind of see these consistent pressures throughout the study, those are the people who tend to respond poorly to pelvic floor PT. And so I will counsel them about that and say, you know, this is what I'm seeing. We're still going to send you to pelvic floor PT because it is the gold standard of therapy, but it might not work. And you're somebody who might need more advanced therapies, possibly even surgery. So that's just kind of, I still kind of have that row in the back of my head.
Yeah, and I think it's a really good point. And I think it also is really important to make sure that whoever is performing this, our nurses, our techs, use the correct nomenclature to tell the patient what they should be doing, like we talked about earlier, and that verbiage, because otherwise it's not exactly the most familiar situation to be in to have an anal rectal manometry performed. You know, you're on your side, someone's putting something in your rectum. It's not exactly the most physiologic situation. So having really good nurses and techs to relax the patient, make them feel comfortable, gets you a much more accurate test as well too. And I think, again, instructing the patient with how to talk to them is what the maneuvers you need them to do is really, really important to get an accurate and helpful test as well.
And that's why at Henry Ford we have a giant mural of a beach scene in our motility lab.
Yeah, picture yourself on a beach with a catheter in your rectum.
Exactly. One other thing that I just wanted to impress upon everybody is that not all pelvic floor PT is created equally. So it's really important to identify the pelvic floor physical therapists in your area and make sure it's legit, visit with them, see what they do, see how they approach these patients. We have this problem a lot because we do a lot of virtual care. So when you tell somebody in Sault Ste. Marie that they need pelvic floor PT, what does that mean? So that can always be kind of a challenge with pelvic floor PT.
And actually one website that I find very helpful is actually what the Michigan Bowel Control Program has actually set up on their website. You can click on the Michigan Bowel Control Program for physician resources and just hit find a physical therapist, and it actually takes the entire state of Michigan by region and can tell you where you can refer your patient as well. And I still use that, even though my joke earlier, they might have canceled me. But it's very, very helpful.
Okay, great.